All right, hey ho, let's go. My name is Dr. MarkAlain Dery. I'm the Medical Director for Infectious Diseases and Chief Innovation Officer for Access Health Louisiana. I live in New Orleans and I serve as co-chair for the ACOI Infectious Diseases Subspecialty Section. Welcome to our public health video blog. And while you best know the ACOI as the place to turn to for quality CME for physicians, both online and in person, the ACOI has been working diligently to keep you up to date by sharing updates with the ongoing COVID-19 saga, as well as expanding our coverage to include other public health concerns as well. Hence, I offer you this regular public health perspective and on to our story, which today is looking at Medicaid and public health. So a little backstory on Medicaid. Get started. Medicaid was authorized by Title 14 of the Social Security Act, signed into law in 1965 alongside Medicare. Now, according to Medicaid.gov, all states and U.S. territories have Medicaid programs designed to provide health coverage for low-income individuals. The year 1965 was also the year immediately following the passage of the Civil Rights Act, and the idea of Medicaid was to help improve access to health care as an important part of the battle to combat poverty and help vulnerable populations. Now, although the federal government establishes certain parameters for all states to follow, each state administers their own Medicaid program differently, resulting in variations in Medicaid coverage across the state. From a public health perspective, that's where the problems start. Now, I live in Louisiana. It's a state that expanded Medicaid in 2016. Now, as a result, a study reported recently that uncompensated care dropped 55% amongst the state rural hospitals in Louisiana. That's great news. Now, as it turns out, the hospitals are much better off in Louisiana because of the expansion than in states like Mississippi, right next door to us, who can't afford it or who choose not to expand Medicaid. As a result, for example, a new facility helping residents of Madison Parish, Louisiana, access care for chronic conditions like diabetes, cancer is being built, relieving many of the travel burden of 30 miles to go to a specialty clinic. And that's what having money can do. But just over the border in Mississippi, where the governor has refused to expand Medicaid, the Jefferson County Hospital and Behavioral Health Unit is struggling. They simply don't have the budget to improve or expand facilities to improve care access. Why is that? Well, because reimbursement rates are too low to cover the costs, and that's what a lack of money can do. Now, with a poverty rate of almost 40% and an unemployment rate of nearly 20% in Jefferson County, Mississippi, it is exactly the sort of place where Medicaid expansion is necessary. And even more so, an economist for the state of Mississippi released a study recently that found that Medicaid expansion would actually be a boon to the economy and likely add over 11,000 jobs to the state. In addition to reducing hospital costs for unpaid care, it would also likely pay for itself within 10 years. Now, regardless, it is not a place. Medicaid expansion has been outright rejected by the governor. This is the sort of scenario that creates a classic public health nightmare. The Medicaid program, which matches federal dollars to state money to provide health care to most vulnerable in many states, means a rough dollar for dollar match. However, in Mississippi, for every dollar the state spends on Medicaid, the federal government spends nearly $5.50, which is a lot more than in any other state. So let's be clear. While the federal law mandates that states cover certain qualified low-income groups such as families, people with disabilities, seniors, pregnant women, and children, it is the state that ultimately decides who is considered eligible. This lack of consistency from state to state is exactly how a Mississippi county has drastically different care access for vulnerable populations and then just a few miles over the border in neighboring Louisiana. So when states like Mississippi don't expand Medicaid, who does it hurt exactly? Well, there are groups that definitely are feeling this pain. Those that are too poor to qualify for the subsidies available under the Affordable Care Act, but are not poor enough to meet the state's guidelines to be in Medicaid recipients. That's the classic donut hole. A ruling by the Supreme Court in 2012 that gave states the option as to whether or not they wanted to expand eligibility, created that gap. So Mississippi, along with 11 other states, including Wyoming, South Dakota, Kansas, Wisconsin, Texas, Tennessee, Alabama, Georgia, North Carolina, South Carolina, and Florida, are creating public health nightmares for many of its residents by refusing to expand Medicaid. And I speak both as an infectious diseases physician and as a compassionate human being when I say that makes no sense. Zero, zip, zilch. I don't understand denying health care to anyone. And I speak purely logically when I say it makes no sense, especially when the COVID-19 relief bill that was passed this past March included a financial enticement for the 12 holdout states to expand Medicaid. The federal government has said it'll cover 90% of the costs for the newly eligible population, plus an additional 5% of the costs of those already enrolled. An analysis by the Kaiser Family Foundation estimated that the net benefit for these states would be $9.6 billion. That's billion with a B. Yet none of the holdouts are taking the payment up on the offer. Jeez. The other part of the Medicaid and public health equation is us, physicians who won't take patients on Medicaid. So that means that many low-income individuals in the U.S. getting insured is not enough to actually get health care. It turns out that once eligible for Medicaid, the next hurdle to overcome is finding a physician that accepts it or going to an FQHC, federally qualified healthcare clinic, which is where I am. The reason which many of you hearing this or ultimately reading about this know all too well is that Medicaid billing is not easy. A recent study found that providers run into more obstacles when trying to bill Medicaid than they do with other insurers, and that Medicaid payment rates, amounts that doctors receive for providing services, are on average lower than Medicare or private coverage, and that almost 20% of Medicaid claims that are made are never paid in full. This turns into an administrative nightmare as providers are trying to sort out rejected or disputed claims. This explains the reluctance of physicians from having to accept it, and I completely understand that. There are also issues with providers who treat Medicaid patients differently, and again, dissecting this from a public health perspective lens, there's also a study that was published in 2015 that found that in the U.S., people of color face disparities to access in healthcare and the quality of healthcare received, finding that most healthcare providers appear to have an implicit bias, basically reflecting a positive attitude toward Caucasians and negative attitudes toward people of color. And another study, this time published last year in the New England Journal, found that algorithms used by physicians to make healthcare decisions are saturated with implicit racism that their designers were unaware of, but were often resulted in fear of healthcare for some black people. And I think we actually reported on that study last year. So for many black Americans who experience this bias and who happen to also be on Medicaid, they have the additional burden of not only finding providers that take Medicaid, but also who don't resent taking it and making less money. There are too many stories out there of black patients being treated differently or who have physicians who are less than responsive to their needs. And while implicit and sometimes explicit bias is sometimes to blame, so is the underlying resentment of knowing they are not making as much money on Medicaid patients as they would with others. All right, wow. So stay on the lookout for these updates, and to read more of the sources used in this report, you can go to acoi.org/resources. Together with the ACOI, we will help you have latest information to help respond to your patients. Feel free to reach out to me anytime at madery@mac.com. Thank you, Gina, for an incredible script, and thank you, ACOI, for letting me make these videos.